Well, welcome everybody. We're going to be starting another one of our Insights World Tour and stop in Canada. My name is Mo Bendari. I'm editor-in-chief of OrthoEvidence. And if you can just for the time being, just stay muted and off camera while we're doing our initial presentations, there'll be lots and lots of opportunity for everyone to engage after we have our presentation from an exceptional colleague and a great speaker on a great topic this evening. So this evening, let me remind you, this is recorded. As I mentioned, again, we'll have lots of discussion opportunity after. And should you want to discuss or have a question based on the topic you hear, certainly do take a moment to come on to video at that time, and we can have a discussion and you get ask your question directly to our guest speaker. We will make sure that we provide the full recordings to all of the participants here as well. And we'll make sure that we also have transcripts available of our discussion this evening. So if I go to the next slide here. So what is the Insights World Tour? These are small group sessions by design, interactions with leaders on topics of interest around the world. Tonight we are virtually in Canada. For those of you who are visiting us from Canada, you'll be a good evening, and for those from elsewhere, it'll be a different part of the time zone. But the point is, we're meant to have interactive discussions, and this has been part of our planning. This particular session, if we go to the next slide here, is also part of another series of talks that we're having that have been partly sponsored through 3M, and the support of 3M through an independent grant that allows us to bring issues around infection as well and challenging infection head on. So we thank our collaborations with 3M to make some of these world tours possible. So what are we talking about this evening? Well, enhanced recovery after surgery is a major issue. And in fact, if we think about some of the innovations across sort of the platform that is joint replacement, while there have been absolutely impressive opportunities to evaluate new techniques and specifically new implants, you can almost argue, and I think I'll be asking this to our guest, whether or not designing a new implant specifically is going to be the solution to answering some of the the big problems of the future. Certainly in hip fractures, I can tell you that it's probably not going to be implant A versus implant B that's going to be changing the way we think about improving outcomes following these injuries. It's going to be a perioperative, really concerted effort to manage the patients before and after surgery. So certainly without further ado, it's my pleasure to introduce Pascal-Andre Vendittoli, who is an orthopedic surgeon, a professor of surgery from Montreal, Quebec, and certainly has spent quite a bit of time thinking about this issue. I will let him talk to you about this particular issue, and more importantly, I'll let him speak to you about this protocol that they've developed. We look forward, Pascal, to your discussion this evening, and then thereafter look forward to having a fairly robust discussion about the implications of the work you've done. Thanks so much.
Thank you very much, Moet. It's a pleasure to be with you tonight and sharing this talk with all the participants. You know, I'm a big fan of orthopedic evidence, so it's really an honor to share this presentation with the whole group. Let me start here. I think it should work out. So, as it was mentioned by Moet, enhanced recovery after surgery is really a significant improvement for our patient and for our practice. I will discuss the impact of this enhanced recovery protocol for hip and knee replacement. But please, if you're doing other type of surgery, fracture surgery, spine surgery, all these principles can be applied to other fields of orthopedics. So with the COVID pandemic, I think not only in Canada, but we were all affected by the impact on our surgical procedures. We had to reduce hospital lengths of stay. There was no bed available, the reduced workload available, no nurse, no physio, no home care. And we needed to minimize complications and avoid infections, nosocomial infections. So what is the ideal solution in this very critical period? We know that enhanced recovery after surgery exists for years, but was not introduced in our practice widely. And this would also impact on our rate of outpatient surgery. So the combination of both enhanced recovery after surgery and outpatient surgery would be the ideal solution in this critical period of our clinical practice. I would recommend you to read this short discussion paper published in the Canadian Surgery Journal, presenting this solution to our major national problem. So there are different ways to achieve outpatient surgery. If we only want to achieve a shortened length of stay, we can make it simple and do a strict patient selection, only picking up the champions. And then the volume of patient that you could select would be maybe 20–30% of your clientele. And you can transfer the workload outside the hospital. Patient could live in a wheelchair, would live with a pain control pump and a very complex technique that need to be managed at home with a large joint dressing for a knee replacement, for example. And then you can transfer the workload to intensive nursing or physio home care. Is it exactly what patient wants and what do we need? There is an increased risk of patient complication, and maybe this is not the ideal solution. Ideal solution is to include in our practice the principle of enhanced recovery after surgery. This was proposed by Killet in a Lancet journal in 2013, so this is not new. What is the basic principle of ERAS? Is to improve the patient outcome to a level where he would be ready to go home sooner and safely. So it's not only to send home the patient earlier, is that the patient can leave home walking with a reduced pain level and feeling great. Currently, are we doing our best? Please listen to this patient testimony. This is a standard total knee patient coming up after 6 weeks after his surgery.
You had surgery on your right knee 6 weeks ago.
Coming out of the hospital for the first 24 hours was very hard. It hurts for me. I had some nauseas. The medication was making me sick. I had some pain, of course, always, and I'm told I had a phlebitis because of the blood and clots and stuff in my legs, so it was really bad. I had hypotension. I had a hard time to move around, and with my cane and stuff was mostly.
Okay. How did your wound heal? Was it healing properly?
I had an infection, and there was a discharge coming out of my wound.
And if you had to do the left knee, would you do it right away, or we would wait some time?
When I lived with this one, I'm telling you, I wouldn't do it now. I wouldn't be ready. It was too much to ask.
So this is a very typical comments of a patient 6 weeks after a total knee replacement that I was hearing about 5–6 years ago, and very hard to convince a patient to do his other side right away. Please make sure to listen to the whole talk and see how these comments of patient change with ERAS principle. So are we doing our best? There is a discrepancy between best practices in the literature that you can see in the great journals or OrthoEvidence website, because it takes years for clinicians to change the way they do things. We know that tranexamic acid is a great tool to minimize blood loss, but in some hospitals, tranexamic acid is still not in practice. And our patients deserve the best evidence care available. So what are the potential problems affecting success? The patient you listen to had list many of these, But the most important after a knee or hip replacement is pain, nausea, orthostatic hypotension, bladder retention, hematoma, wound problem, loss of motor function, anemia, DVT, and infection. Each of these problems will be a hurdle for the patient to leave home after a day's surgery, and will change the outcome of the patient. So what we did in the last 6-7 years in Canada, there was an organism created like Enhanced Recovery Canada, based on the International Society. And also we have the Healthcare Excellence Canada, which is a new organism with a relentless focus on improving healthcare for every Canadian patient. So the basis of these two organisms is to really provide the optimal care for the Canadian patients. So as a group, they contacted me, and I was able to get 20 experts across Canada to do a consensus clinical pathway for inpatient and outpatient hip and knee arthroplasty. So we created that document that you can find on the Healthcare Excellence Canada website. And this consensus pathway is really a kind of a cookbook how to do ERAS outpatient surgery. And today, the presentation, I will try to go with you on the most important part of this cookbook. So the ERAS 6 core principles that can be applied to all surgeries is first, improve patient nutrition, mobility, obtain the patient engagement. We want to have an appropriate preoperative fluid management, pain relief, and also include all the best practices available in the specific field of surgery. It will involve multiple interventions throughout the whole patient recovery period. It is a multimodal concept. So not all interventions are needed for every patient, but they are needed for the success of the whole cohort of patients. There might be limited or controversial scientific evidence for specific interventions, and you may have some doubt about why are we doing this? Why are we including this specific drug? But it is in the multimodal approach, it is the combination of all these interventions that will create the effect that we desire. It is a teamwork. We want to involve the patients, nursing, physiotherapist, administrator, surgeon, and anesthetist. If one of the team members do not follow the recipe, it will be a failure mainly for the patient. So what we did in our center when we started to do ERAS outpatient program, we created our recipe book. We did some systematic prescription that the whole team will need to follow from the patient selection to the patient discharge, and nobody could do his preferred method. They would need to follow the strict protocol. This is a systematic approach that will really offer the best result on our patients. So it starts in the office with patient selection. These are the exclusion criteria, and they are very minimal. I mean, we included in our center about 70% of my patients are suitable for this ERAS outpatient surgery protocol. When we meet the patient first, we need to get his engagement. At the time of the surgery, there is no time to teach the patient what will happen. You need to do this beforehand. You need to come to the day of surgery knowing that he will leave home on the same day. And it is the job of the doctor, the nursing, the physiotherapist, and we need some time to be able to teach all these important facts. So the patient, when is well prepared, will have a very lower anxiety level. He will take fewer painkiller pills, and he will agree to leave earlier. We created some guides that you can also find on Excellence in Care Canada, guide for hip replacement and guide for knee replacement. They are available in French and English, and they are specifically written for the patients to be able to be prepared for a surgery. You can also visit the precare.ca website. This is an incredible information source for the patient. There are multiple videos for total knee, total hip preparation, following the enhanced recovery after surgery principles, and available in multiple languages as well. It has been designed to be understandable by people who are of pre-college education. When people, before surgery, one very important part of ERAS is to optimize patient. We need all patients to meet an internal medicine doctor to modify all the risk factors that can be done. You know, a patient with anemia need to be treated before the surgery, because we know, for example, it has a specific impact on the need for blood transfusion, for example. The patient will need anesthesia if needed, nurse to review selection criteria, review allergy, stop smoking, reduce alcohol, because we know all these two factors have impact on healing after surgery and risk of infection, and do MRSA screening if it's important in your area. Nutrition is also very important. All the patients historically were following a prolonged fasting, which is inappropriate. Orthopedic patient, if we follow the new guidelines, can eat normal meal up to 8 hours before surgery, light meal up to 6 hours before surgery, and up to 2 hours before surgery, we encourage them to drink a sugary liquid, like a clear fruit juice, for example, to maintain their blood sugar level and improve their recovery after surgery. On the surgery day, patient will need to do a chlorhexidine soap shower in the morning of surgery at home. He will follow the limited fasting protocol, and he will receive a cocktail medication involving here 6 pills, including acetaminophen, Celebrex, Lyrica, scopolamine patch, apripitan, and OxyContin, which will probably be the only opioid that the patient will receive throughout the whole post-operative care. In the OR, we'll give him tranexamic acid 1 gram IV and dexamethasone 4 to 10 milligram, 4 milligram for diabetic and 10 milligram for people who are not diabetic. In the OR, we are proposing at our center an anesthesia method that is quite innovative, because we know that the ideal anesthesia method should minimize duration of loss of motor functions, minimize or avoid use of opioid, avoid sedation, minimize post-operative orthostatic hypotension, minimize urinary retention, maintain normal thermia, and also avoid fluid overload. What is the ideal solution? In our practice, we decided to use a multimodal technique, combining a light peridural with a deep sedation with propofol. We say multimodal because if we do each of these two techniques separately, you cannot do the surgery, but the combination of both allow you to do the hip replacement or knee replacement. And as you can see on the video, with this technique, patient keep full motor function during the whole intraoperative period. It's an opioid-free technique. There is no benzodiazepine, and it minimizes orthostatic hypotension after surgery. During surgery, we would recommend minimize soft tissue dissection, a careful hemostasis. We don't use tourniquet for total knee and no drains. We use a large amount of local infiltration anesthetics with 400 milligrams of ropivacaine in 200 cc's of saline, plus toradol and adrenaline. I would recommend you to read the paper we publish using these large doses. And in my experience, if you don't use this full amount of ropivacaine, you will not get the result we obtain in our practice. With these large amounts, you will reduce pain post-op, reduce narcotic consumption, you will not impair muscle function, and also patient will be able to walk and deambulate freely after surgery. Wound closure technique is also very important. If you want the patient to go home walking with a light dressing, you don't want a wound that will have a discharge after surgery, because patients feel that this wound discharge is like an hemorrhage. They're stressed, they come back to the emergency unit, and this will not be favorable for recovery. What we favor is a skin closure with subcuticular suture, and in the superficial layer, we'll apply we will seal the wound with some mesh and glue. So having sealed the wound, as you can see here, will minimize wound discharge, will prevent contamination with dressing change, and also patient will be allowed to shower very early after surgery. So it's a barrier for contamination. There is no staples to be removed, so it minimizes intervention at home by nurse. Patient can shower the first day after surgery. It creates a nicer scar. And I must say that for patient, it's a game changer. It's improving their satisfaction of the overall surgery. Specific intervention that we do for total knee, we keep the knee flexed at about 60 to 80 degrees for about 2-3 hours after surgery. Keeping the knee flexed will prevent hematoma formation, so we don't want to use drain. It is our way to minimize this potential collection of blood into the knee. And we also use compressive cryotherapy after surgery to improve venous flow, and also reduce pain of these total knee patient. In the post-op period, we use a multimodal pain management. We don't want to use IV, subcute narcotics, or PCA pumps. It was a major change for us in the recovery room, for example, because we had to ask them to have only tablets. We don't want them to give, as I said, IV or subcute painkiller. We want to remove all catheter as soon as possible, resume a normal diet as early as wanted, and you will see that patient, if they feel good, they have no nausea, they are ready to eat their lunch almost an hour and a half after surgery. When they return home, we give them the appropriate information with a really comprehensive document. They need the patient to bring them back home. They have an emergency contact number. Usually, we will try to phone them day 1 to day 3 to make sure that they're doing well, and they receive a visit by physio and nurses at home in the first 3 days. So what are the results of this ERAS outpatient program? We published the result of our program that we started in 2016 in this journal. It's an open access if you want to read it. We were able to reduce 50% of the adverse events of our patient if we compare ERAS outpatient group to a standard inpatient group that we did in the previous years. And this is in addition to reducing the hospital length of stay. So it's a double benefit for the patient. If you look at the adverse event that we reduce, all significant pain, anemia, nausea, vomiting, headache, pain, dizziness, constipation, hypotension, edema, all these things that we were targeting with our interventions were significantly reduced in our cohort of patients. If you look at the economical value of this protocol, because we were able to reduce the hospital length of stay, which is significant cost, we saved to our center about $4,000 per total knee replacement and about $1,500 per total hip replacement in Canadian dollar. So this is a major save for our administrators. Here, I want to share with you the experience of two patients. These two patients received one knee or one hip with the standard technique and the other side with the ERAS outpatient protocol. So just please listen to them and you can compare their experience with the previous patient who had so many problems with his total knee replacement.
What was mainly the recuperating time, it was just much faster with the on the left knee. Like I mentioned earlier, I was walking with a cane probably 5 or 6 weeks after the operation on the right knee, and within a week after the left knee operation, I didn't need a cane anymore. So, and there's virtually no pain in my knee at all.
Did you had to take some pain medication for the left knee?
Yes, we took Tylenol.
Tylenol?
Yeah.
Regarding the physiotherapy, did the physio told you that you were faster with one knee versus the other?
Yeah, the left knee, she said I'm 6 weeks ahead of where I should be right now.
6 weeks ahead of the your schedule.
Yeah.
Okay. You had a problem with your right knee because you were unable to void and to go to the bathroom for more than a day.
Yeah, from the anesthesia, and from the anesthesia on the right knee, I was almost a day and a half before I could urinate, and on the left knee, I was in the afternoon because I was operated on about 11 in the morning, and 3 or 4 in the afternoon, I went to the bathroom.
Okay, good. So for you, the overall, you believe there was some benefit of having the procedure the way it was done on the left side?
Oh yes, no question.
So if you had a third knee, which one you would select?
The left knee. And also only one day in a hospital, it makes a big difference too.
Okay.
Because you rest much better at home.
You see, very interesting, because these patients has all the answers. They can share very easily what are the benefits of the protocol, and you see that every patient will face different problems if you do only the standard procedure. When you do ERAS, then you can solve all these problems. Let's listen to this one who had the right total hip done the standard way and left total hip with the ERAS way.
So you had the left hip done with a rapid recovery protocol and the right hip a few years ago with a standard procedure.
Both recoveries were quite good. However, the new one I just did, it was fantastic. I was ready to go right away. I didn't take any painkillers. After a week for the second operation, I was done with the crutches. I didn't need them. The first operation, I think I was using them for about a month. The physiotherapist that was coming to my house, she was like amazed. Like I was in no time going up and down the stairs, and I had full mobility almost.
Did you experience some nausea, dizziness, hypotension? Okay.
Not at all. I was in great shape right away. Like I had no pain. I literally had hardly any pain whatsoever. My physiotherapy that I did for the month, I was doing everything. No, there was no pain. The progression was really fast. I'd say the rapid was the best experience.
So very interesting. I think this is talking, and this is only two patients that I had in English speaking, but so many of the patient have similar findings. And to try to put these comments into numbers, I review my first 48 patients who had both technique done on one side or the other side. And so I've got 48 cases that will be soon published. And if you look at their subjective perception and the objective results, both group had not very high pain in the recovery room or in the ward, very similar. But look at the consumption of opioids. So it means that opioid, yeah, it's a really effective method of reducing pain, but it has all these side effects. And what is the great finding here is that the ERAS outpatient were having the same pain level, but consuming almost no opioids. If we look at the functional recovery, and this is the real key here of the anesthesia technique I presented you, is you look at the differences in a week or in days of using a walking aid or going up and downstairs without any technical aid. You see there is a significant difference favoring all the time the ERAS outpatient, first shower, be able to do their activity of daily life, mild physical activity, intense physical activity, and also returning to light duty work or returning to regular work, all favoring the ERAS outpatient group. But I want to remember you that it is a direct comparison of the same patient having both procedure. When we asked the patient how they were satisfied with the time in hospital, pain management, their overall recovery, wound closing, and in general, you see here almost a perfect score for the ERAS outpatient. You see here standard inpatient is not too bad, 80%, but still we are reaching almost perfection with an optimized protocol. When we asked them which side they would prefer, you see 85% would prefer the ERAS outpatient versus 6% for the standard inpatient and no preference in 10%. So what is the different, how can we explain these results? The same patient, same surgeon, same surgical technique, same infiltration, same implants. I would say there was 5 differences in the old process. The use of aprepitant, which is an anti-nauseous drug that we included in this protocol, the anesthesia technique, which is a combination of epidural and sedation. It is not a spinal. Dexamethasone, patient experience, so they already had their other side done, standard way, and also patient expectation that was not blind. But in my view, with the experience I have with this protocol, implementing this protocol in now 4 hospitals, I'm sure that the anesthesia technique is really the key of success of this protocol. So in a resume, the ERAS outpatient surgery benefits create less pain, fewer complications, faster recovery for the patient. For professionals, we feel that we're doing our best. And for the administrator, it has a lot of favorable impact. So you can convince them to help you introducing this protocol in your practice. This is very interesting. Orthopedic Evidence reviewed the whole literature to compare outpatient surgery with standard inpatient. What is their conclusion? Non-inferior. To me, this is not the goal. We don't want to be non-inferior. I demonstrated that we can do much better than inpatient if we combine outpatient surgery with ERAS principles. In summary, as I said, I mean, we with this principle, we can improve the whole perioperative care of the patient. We can start introducing this protocol slowly, going from as a stepwise in your center until you reach full adoption in your group. And I must say that this is really something very rewarding, because the nurses, the physio, the surgeon will really feel the benefit of the patients. So this is let's conclude what I had to share with you. I will leave this slide here with the details where you can go on the Healthcare Excellence Canada website to download the documents. And I would be more than happy to discuss with you some aspects of this protocol. And I'm sure you have many questions.